I sense people are ready to start. There's a sort of a quietening in the room. Good morning, ladies and gentlemen. Thank you for coming to this forum on this beautiful Toronto morning. And, you know, this forum is for you, but it wouldn't be possible without the partnership between the Canadian Spondylitis Association, SPARCC, which is the Spondyloarthritis Research Consortium of Canada, and the Arthritis Society, and the sponsorship of Abbott Immunology. And I have to say a great big thank you for the wonderful organization skills of Maria Morales here on my right. Thank you, Maria. You've picked up some pieces of paper after you registered, and one of them is the program that we'll be following very closely. The other two are colored forms here. The pink form is an evaluation form, and it's really important that you fill this out on leaving and hand it in to anybody with one of these name badges on with a SPARCC sign on. So please let us have your feedback. It helps us do better forums for you in the future. We do read these and we do take note of your comments. So please do give us your comments and your feedback on those. The other thing is the green form, ask the experts and create awareness. Questions are really welcome, but for the sake of time, if you can please write down your questions after any of the presentations or during the experts panel at the end of this morning, and hand it in again to anybody with a SPARCC name tag on here. That would be wonderful. So we'll get started. I'm Michael Mallinson. I'm president of the Canadian Spondylitis Association, and we're here for you, and I hope to make sure that all of you leave being members of the Canadian Spondylitis Association. I know we've got quite a few members here, but if you want to sign up, you can be through our website, or there's some application forms at the back. Membership is free, and before I proceed, I just want to have a little bit of an exercise. We're going to take 1 minute. I'd like you to turn to somebody that you don't know in the room, and I want you to exchange 2 pieces of information with them: what they had for breakfast this morning, and whether they have AS or PSA, or whether they're with somebody who has PSA or AS. So can you take 1 minute to do this? That's your minute, thank you. Okay. Okay, we've had 1 minute. So here's what we're going to do with the information that you've just gleaned. The information about breakfast you can throw away, except, by God, who actually eats raw herring and olives for breakfast? Oh, sorry, Norwegian back there. The other piece of information is pertinent to this. Friendship is born at that moment when one person says to another, "What, you two? I thought I was the only one." How many people in this room have never been in a room with somebody with spondyloarthritis before? Look at that. You are not alone, and I hope you've made friends here. I think that's what the Canadian Spondylitis Association is here for, is to be friends to everybody with spondyloarthritis, let you know that you're not alone and that we support you. If you become a member, we do send out a quarterly newsletter called Talkback, and this is also available online through the members-only department. But it just lets you know the latest news and, you know, human stories as well. So that's all part and parcel of it. Why is the Canadian Spondylitis Association important? I'd like you to look at this slide produced by ASAS and EULA. ASAS is the Ankylosing Spondylitis Assessment International Group, and EULA is the European League Against Rheumatism. Rheumatism is the word that they use in Europe mostly for arthritis. I want you to ignore the 2/3 of the slide on the right and the left-hand column. Look at that. These are treatment options, recommendations for the management of ankylosing spondylitis. Education, which is what we're doing today. Exercise, which we're doing today. Therapy rehabilitation, which you've probably been through. Patient associations and self-help groups. And that's what we offer in Canadian Spondylitis Association. I'm going to get on with the program pretty quickly now. So we'll follow the program. Just one thing I want to make sure that you're aware of. We are having our annual general meeting here in this room at 11:10. That's when everybody else is breaking for lunch. So for lunch, you can exit those doors there and have lunch. You can actually bring it back in here. But anybody who's a Canadian Spondylitis Association member probably has a colored index card. If you could come up to the front here. If you're a member and you haven't got a colored index card, just come up here and we'll check off your name against our membership list. But we're going to take a few minutes just to have our annual general meeting, and we need to vote on a motion. So please, anybody who's a Canadian Spondylitis Association member at 11:10, when everybody else goes off to eat, stay in here. We'll take a few minutes. There's lots of food for you afterwards. And how do you become a member? You can sign up online, www.spondylitis.ca, and there's brochures at the back of the room where you can also find brochures from the Arthritis Society and our sponsor, Abbott. I'm going to introduce you to Dr. Robert Inman, and in the past I've sort of said he needs no introduction, and I don't think that's really fair, because although he's been a huge friend to the Ontario Spondylitis Association, which, by the way, is just becoming a chapter of the Canadian Spondylitis Association effective June the 30th. It has been operating under the auspices of the Arthritis Society, but it's becoming part of the Canadian Spondylitis Association June the 30th. So Dr. Robert Inman has been a huge friend to the Ontario Spondylitis Association since its inception in the middle of the 1980s, and also to the Canadian Spondylitis Association since its inception in 2005. Dr. Inman completed his undergraduate degree at Yale University and his medical degree at McMaster University. He did his training in internal medicine at Vanderbilt University and his fellowship in rheumatology at Cornell, based on the Hospital for Special Surgery. He worked as a research fellow at the Hammersmith Hospital in London before returning to a faculty position as assistant professor of medicine at Cornell University. He then moved to the University of Toronto, where he was appointed associate professor and subsequently professor in the departments of medicine and immunology and attending physician at Toronto Western Hospital. He was director of rheumatology at the University of Toronto from 1991 to 2002. He is currently director of the Arthritis Center of Excellence at the University Health Network, and he's a director of the spondylitis program at the Toronto Western Hospital. Effective yesterday, he's also president of SpARCC, the Spondyloarthritis Research Consortium of Canada. Dr. Rob Inman, thank you.
Thanks very much. It's great, as Michael said, that the outline of management of spondylitis very much involves this kind of event. Patient education is a key part of how to deal with this disease. And as you know, so anyone in the room that's been through our clinic at the Western, we regard this battle as very much a partnership between the physicians and the physiotherapists and occupational therapists and most fundamentally the patients themselves. We are learning more and more about this disease primarily because of the patient involvement. And indeed, setting the research agenda for our program comes really from discussions like this about listening carefully to what we hear from you about where we should be going with the program. So I'm going to make just a few remarks about just some updates. In many ways, I wish this was a roundtable discussion where we had the opportunity to dialogue directly as we go. But as Michael said, just because of logistics, we'll hold the question period till the end. But please notate questions as we go along, and we've got a good block of time to actually have the kind of dialogue that I think makes today so important. So backs are pretty critical. There's no one in this room that needs to be told that regardless of what career you undertake, having a pain-free and mobile back is very important. This has been, we're doing some collaborative studies with the NIH that looked at which kind of professions patients with ankylosing spondylitis are best fit with. And there's some interesting data coming out of that. Not surprisingly, careers that involve gleaning, as in this case, or car mechanics, electricians that are bending over, basically any job that requires a lot of back mobility impacts the quality of life and the quality performance in the workplace. So for the clinicians, and when we're talking to our medical students and residents, and this is one of our great challenges, is to heighten awareness of ankylosing spondylitis amongst the medical community. That's really, really what we're all about. So the onset of back pain really is it has a characteristic profile. This is important when we're talking to our students and our GPs because there are many other causes of back pain besides spondylitis. What we want to make sure they're attuned to is the earlier recognition of the disease. So onset of back pain before the age of 40, and it starts slowly rather than abruptly. It's chronic, of course. It lasts longer than 3 months. Many other causes of back pain are rather short-lived, associated with significant morning stiffness, and it generally improves with exercise, but not with rest. Now, there are many people in the room. If we took a vote in the room, which of these would fit your own particular history, there'd probably be a wide variation. But these are themes that have come out of international collaborative studies, particularly with the BATH program in the UK and also with our own program here. We did a study with the Spondylitis Association of America to look at actually at what point the back symptoms really became most prominent. So this was a sample of about 2,500 patients with spondylitis. And you can see that it peaks in the ages 20 to 40 is generally the onset of back pain. But in one interesting group here, and Shirley C., who will be coming up talking about pediatric disease, is very interesting. You can see that almost 20% of our patients have onset of disease under age 18. This is what we call juvenile onset ankylosing spondylitis. And they're a wonderful group of kids there, but they're plagued at a critical time in their academic and social lives in the late high school, early college years with the onset of this unexplained back pain. And it impacts their sports and their social functioning, and it presents a whole unique set of problems for those adolescents at that time. So when we ask that question, as you can see here, the dominant symptoms, whether you are really this stiffness, this propensity for inflammation in the back, and it certainly affects the neck, other joints as well, the rib cage. You notice here that almost 28% of this cohort have iritis, and I think we're in our clinic at the Toronto Western, it's about 32%. So about a third of patients with ankylosing spondylitis will have intermittent episodes of iritis or uveitis. And peripheral joint involvement can occur too, particularly heel pain. If we ask in this large sample how it really did impact their lives. Now, I'm sure you can relate to many of these, but everything from participation in sports, running, getting a good night's sleep, getting into the car, just about any aspect of your professional and social life can be impacted very significantly. We've just completed a study with Aileen Davis at Toronto Western Hospital. She's a social scientist that looks at quality of life measures. Some of the questionnaires we do, and many people who come to our clinic are fed up with our questionnaires, but that's another story. The functional index, for example, that was developed by Andre Kalin in Bath, is a 10-point questionnaire that very much asks how you're capable of doing a particular maneuver. Are you able to put on your shoes and socks in the morning without difficulty? Can you look over your shoulder without turning your body? And these are functionally important measures of back mobility, but it doesn't quite capture the magnitude of the impact of this disease on a person's life. And so what Aileen has just published a paper looking at what we call participation. How do we capture both the magnitude of the disease, so how it impacts not just these simple daily functions, but how does it impact leisure activity? Are you still able to play with the kids on the floor? Can you put out the garbage or rake the leaves? Now, see, there's some advantages of being disabled if you get to, but actually how you capture also the improvement after biologics. One of the challenges has been we can measure things like pain scores after the introduction of effective medical treatment, but there's a far more global improvement in quality of life once we actually get the disease under control. And so it certainly affects every aspect, psychologically, emotionally, and I think particularly the age and the demographics of this disease. Many of our patients, being in their 20s and 30s, they just didn't anticipate having arthritis at that stage of their life. It's coming at a critical stage, and it can be profoundly discouraging, particularly if there's a long delay in diagnosis. And there is a long delay in diagnosis at the moment. So this is the data from our questionnaire from both Canadian and American data sets. So this asks, how long from the onset of your back pain to the time of diagnosis? Well, how long was that interval? Now you can see that if you split just north of that, the north part of that pie chart would be people that have at least 5 years of symptoms, and that's about 50% of patients. So we have a number of patients, like the right lower quadrant there, that have between 6 and 15 years of symptoms before the diagnosis is made. Now, this is really a challenge, I think, for the rheumatologists, because we have an education challenge presented by this slide, which basically has to do with what's the point of first medical contact with our patients? Because it's not a rheumatologist. It's either a primary care physician or a general pediatrician, or it's a chiropractor, or it's a physiotherapist, or it's a sports physician. It's somebody. There are many points in our medical and allied health professional system that have a first point of contact for back pain. It's not really the rheumatologist. So we need to actually educate those first contact individuals, the allied health professionals as well as the physicians, to be much more alert and sensitive to ankylosing spondylitis. This is really, in the minds of our patients, and certainly our minds, this is really unacceptable to have a delay that's that long. And in those years before the diagnosis is made, I'm sure you can relate to that, many of our patients have seen acupuncturists and herbal therapists and psychologists and sports physicians and a wide variety of different approaches to back pain until the diagnosis is finally made and we can actually get on with it. And it does make a difference. This is data from Millicent Stone, who worked with us. The longer delay in diagnosis actually affects outcomes. So not only do we owe it to our patients to do better in earlier diagnosis for quality of life reasons, we need to do better because the long-term outcomes are much better. And effective intervention earlier on in the disease leads to far better outcomes. So how do we actually communicate that to our GPs and our physiotherapists and our chiropractors? Chiropractors, there are a lot more chiropractors in the province of Ontario than there are rheumatologists. Right? There are about 140 rheumatologists in Ontario, there are 2,400 chiropractors. And an average chiropractor is about 75% of their business is back pain. So it's very important that we have an effective dialogue with that group. And so I've given lectures at the chiropractic college to the chiropractic students up there to at least alert them to the signs and the symptoms of ankylosing spondylitis early on. And so these are some of the clues. Besides the characteristic features of the pain, we would actually like them to be aware of some of the other features. One, for example, at the bottom, the extra-articular features, about a third of our patients have iritis, as I mentioned, and about 10% have psoriasis, and about 10% have Crohn's disease or ulcerative colitis. So another very important interface for the rheumatologist is with these other medical specialties. So we interact very actively with the inflammatory bowel disease clinic, with the dermatology clinic, and also with the ophthalmologist, because it's not unusual that the first medical contact might be with the ophthalmologist or the gastroenterologist before they finally come around to see us. So the hallmark of this disease, as you know, is sacroiliitis, and we place a great value on the X-ray changes. It's a very distinctive joint. The sacroiliac joint anchors the spine into the pelvis. It's not a mobile joint at all. It just anchors it, and it has essentially no flexibility. It's a cartilage joint represented by that dark, let me see, pointer here. This dark line right down here is essentially cartilage, and that represents the sacroiliac joint. And for reasons that we as yet still don't understand, that is the target joint and for the inception of ankylosing spondylitis. So as a result of the inflammation that occurs along this joint underlies the stiffness and the back pain that's the hallmark of the early disease. And indeed, the changes that are seen in the sacroiliac joint really anchor the the diagnosis in many cases. Besides the changes in the sacroiliac joint, we also have changes in the spine throughout. So the normal curvature in the spinal vertebral body is lost. And eventually, as you know, a lot of this restriction in spinal mobility, whether it's in the forward or the lateral plane, has to do with these bone spurs. So the bone spurs are these little bony extensions that cross the bridge across the intervertebral body. So the spine is beautifully constructed in the sense that each vertebral level just allows about 5 or 10 degrees of motion, but in the aggregate, it allows us to bend over and pick something up from the floor. That's when those bony bridges limit that flexibility at each level of the spine, then it really restricts spinal mobility very significantly. So one of the other outcome measures, of course, as you know, in our clinics is to systematically measure spinal mobility, so we have a sense of the trajectory of the changes in pain. So inflammation in the eye can occur. We work closely with our ophthalmologists. Besides, the heel pain is very common. So Achilles tendonitis has probably been experienced by many patients in the room here. And one of the challenges for us then is to recognize the reality of these other allied health professionals. So a busy GP who's got a certain time window to see a patient, because he's got a lot of patients waiting in the waiting room, who's presented with a young patient with back pain, we need to give him or her a simple algorithm that they can apply to that. And that applies also to the chiropractors. We'd like to give them a simple approach so at least we heighten the awareness of early ankylosing spondylitis. So we alert them to the characteristic features of the pain. And then the pelvic x-ray is very important, and then the sedimentation and an HLA-B27 test. And at that point, if we could start to alert the first point of contact for the patients, we could actually make a significant inroad in this unacceptable delay between the symptom onset and the diagnosis. Now, besides that, now as I mentioned, one of the big developments in the spondylitis community in the last 2 or 3 years is the fact that, as I mentioned, the radiographic sacroiliitis. So that's the distinctive change that we see on the pelvis X-ray. But it takes a long time for those X-ray changes to occur. It may, in some cases, this takes several years. So even if a GP says early on, oh, this might be ankylosing spondylitis, if the pelvis X-ray is normal, the patient leaves the office without a diagnosis. So what we realize now is that there's a long stage before those distinctive X-ray changes occur. There's what we call a pre-radiographic stage, where there's inflammation there, but it has not yet resulted in any changes in the X-ray. And for this window, the big change here has been MRI, magnetic resonance imaging. So this now allows us to, with more confidence, identify inflammation as the cause of that patient's back pain. So that's been a significant advance because we know that it moves us in the timeline of this disease. It now allows the physicians to make a diagnosis earlier and, of course, to intervene with effective treatment earlier. And this is what we're looking at on the MRI. So the pelvis X-ray on this patient was completely normal, but on the MRI, which for those that have had it, there's no radiation exposure, but you slide into a little circular tube, it takes anywhere 45 to 60 minutes, and what we're detecting here, this white spot is actually water accumulation. So it represents a focus of inflammation that occurs in the spine. And this has really been a big advance in terms of the early diagnosis of ankylosing spondylitis, because it now allows us to, with more confidence, help stratify whether or not the source of the back pain is coming from inflammation. It's a big issue in the Canadian healthcare system because access to the magnets varies widely across Canada. So you can wait 9 to 10 months if you're living in Newfoundland, even parts of Northern Ontario. We're very fortunate at our center because we have a very strong arthritis radiology team that works with us. But that one of the challenges is to make sure that physicians and the patient have appropriate access to diagnostic modalities like this. So as Michael said, the Spondylitis Association, Research Consortium of Canada, has really been working in partnership with the CSA, the Canadian Spondylitis Association. And this really grew out of a conference in 2004 that was sponsored by the Arthritis Society and led to the formation of both bodies about the same time. Prior to this, there had been several strong organizations, but they merged into one central organization called the Canadian Spondylitis Association. So we were asked recently about the birth of SPARCC, and we think it's there's an astronomer has actually found this was a supernova that occurred in 2004 that really changed the universe of spondylitis in Canada. Bringing it down from the stratosphere back to the Canadian landscape, our goal has really been to ensure that right across Canada, we've got both expertise on the medical side and advocacy on the patient side. So the vision has been very much to build partnerships, such as is represented today, between the medical community and the patient organizations. And so the vision for CSA and SPARCC has been to partner in each province, one champion physician who will be the lead go-to person for ankylosing spondylitis, and 2 patient advocates. So we've been working on that vision, and still to this day have been trying to make sure that every part of the country, the patient, regardless of where you live, you're going to get expert attention. So the vision, when SPARCC established the program, the research program, we realized it's a complex disease. It impacts not only every aspect of an individual's life, but if you look at the global impact of a disease, you can break it down into different subcategories. So molecular and genetic basis of disease is, there's a lot of activity going on at Toronto Western Hospital. This really looks at the genetic aspects of what drives the inflammation. So we know HLA-B27 is a very important gene. That was recognized in 1973, that's quite a while ago. And it's just recently that we've been able to shed some more light on how B27 actually works. It's a gene that occurs in the normal population. So 90% of our patients that have ankylosing spondylitis have this particular gene. But it occurs in 7% of the healthy population. And if you turn the equation around the other way, about more than 90% of patient individuals with that gene are fine. So it's not like a disease like sickle cell disease. If you have the gene, you have the disease. This merely increases the likelihood of having the disease, but it's a very important gene right across the globe. And wherever you look around the planet, where there's a higher frequency of HLA-B27, there's a higher frequency of ankylosing spondylitis. So working with Proton Raman in Newfoundland, we have collected DNA samples from right across Canada to ask what other genes actually could be contributing a role here besides HLA-B27. And so the Canadian group was amongst the first to identify another gene called ERAP. And it's a gene that actually interacts with B27. It puts peptides into this, on top of this protein structure. So and there's several other genes, one of which is interestingly is shared with Crohn's disease. So the clinicians always knew that there was something about Crohn's disease and spondylitis that shared a common susceptibility. Now we understand that there's a gene, it's called the IL-23 receptor, that actually is shared. The gastroenterologist knew about it, the rheumatologist, and then we realized that patients that have AS and Crohn's disease have that gene as well. There's a lot of clinical research undergoing. As you know, it's been since the inception of the biologics in almost 2001, 2002, the first anti-TNF agents, the third in 2004, and then 2 years ago, a fourth. So we now have in Canada, Health Canada approval for 4 anti-TNF agents for ankylosing spondylitis, which 10 years ago was just unthinkable. It's just remarkable how it has changed the landscape. And there are new biologics coming down the pike very shortly. Health services research, an important issue about how is the healthcare system up to the challenge of dealing with an expanding, increasingly recognized group of patients with AS. So this involves access to appropriate care. So we're concerned very much about medical manpower in the province of Ontario and across Canada to make sure that, for example, access to diagnostic procedures like MRI is important. As Premier McGuinty is facing a shrinking healthcare budget, as you could read in the papers, this is a very important issue for us, that we stand up and make sure we're standing in the role of patient advocates, that nothing that is done in the province of Ontario will jeopardize the diagnosis and management of ankylosing spondylitis, and we've taken that stand very publicly. And finally, population health. There are issues right across Canada that are peculiar to certain populations. At our scientific day yesterday, Kevin Keane from the University of Northern British Columbia, he's in Prince George, has been looking at ankylosing spondylitis in First Nations. So it turns out that in parts of the First Nations tribes in Western Canada, the HLA-B27 is quite a common gene. And so ankylosing spondylitis occurs with a greater frequency. And yet, in parts of Canada, as you're well aware, healthcare is really suboptimal for our First Nations Canadian colleagues. And access to diagnostic imaging, and particularly of concern to us is that it may not be a level playing field in terms of access to a biologic. So we're working with the rheumatologists in British Columbia, and Kevin in particular is looking at a prevalence study of spondylitis in First Nations, because we should also take the stand that there should be no Canadian with spondylitis that's denied optimal access to care. So the genetic factors, as I mentioned, are critical, and we think that this has really changed the landscape of the activities that SPARCC's undergoing now, which involve studies right across the spectrum of medical research. We're going to be seeing some exciting new data coming out very shortly from what's called the genome-wide association study, where we take DNA from AS patients right across Canada, and we study them with hundreds of thousands of these small little genetic markers to determine any new genes that might be involved. The last point I would make about that is that this is very much a collaborative study, not only across Canada, but around the globe. So we are in these genetic studies to have an adequate sample size to determine the presence or absence of new genes. You really need not hundreds of patients, but actually thousands of patients. So in the genetic studies that we're undertaking, we work very closely with a group in Brisbane, South Australia. So a lot of the genotyping is being actually done in Australia. But it's a collaborative study with the British. So there's a very active group called the National Ankylosing Spondylitis Society in the UK, which is the CSA counterpart. We work very closely with that group. And then in the US, we've actually collaborated and pooled all the DNA comes into an international consortium. And the counterpart of the CSA is the Spondylitis Association of America. And so we now have very close links with several expert sites of AS. So the Toronto Western group is now collaborating with a group in Houston, Texas, Cedars-Sinai in Los Angeles, the University of California in San Francisco, and the NIH in Bethesda, Maryland. That's a wonderful dialogue because first off, it expands our collective wisdom because we're always talking to each other, either online or on the phone or at international meetings. But it also allows us to pool resources. So some development that's taking place in San Francisco will hit real time in the Toronto Western Clinic within a day or a week. So the electronic age has facilitated that. And finally, the international aspect of that is very much facilitated by our training. So we've been very, very fortunate in our program to have international trainees currently from the UK and the United Arab Emirates. We have trainees that are based now back in Singapore. So these are patients that would come to Canada to learn expertise in ankylosing spondylitis and then return to set up a spondylitis clinic back home. And one of the most active is in South Korea. So Professor Taiwan Kim directs the spondylitis clinic in Seoul, South Korea. And we have an active ongoing dialogue. In fact, it's almost like he's still at the Western because he's in Seoul, I'm in Toronto, but we share thoughts and research resources on an ongoing basis. So that's a short introduction to what the SPARCC is doing and the exciting forefronts for spondylitis research. And I'll turn it back to Michael.